Hey everyone, how's it going? I don't know if you guys can hear me, if it sounds. Wait. Did we finish up the derm section last time? I do not recall. 7 days ago feels like 7 weeks to me. Guess I could try looking at the. Ego was the 15th. Well, it looks like we finished that one, so I'll get out of that. We're on schedule, which is odd for me. Good though. Would you like to us to know the dosing milligrams per interval for the drugs? No, I never. I don't usually ask dosing questions on. It's for clinicals and later time for you to figure out dosing and whatnot. You can always look that stuff up. But I always say if you don't know what drug to go with in the first place, it doesn't matter if you knew the dose to begin with because you don't know to use the drug. Well, I mean, I know drugs in terms of like how do you use them, like what are the side effects, mechanism, kind of stuff we talked about. Write the exam questions for the hematology section from last. Okay, that's fine. You guys, group watching, all that. Yeah, this had to be at 10 due to some scheduling issues on with my main job. So not sure if you guys have class like right after or whatnot. It's fine if you're already on campus and all that. So maybe you can be the moderator for questions if they have any. I think we finished up the derm section, so I'm gonna go ahead and get started on ENT this time around. Being on schedule is uncommon for me, so I mean I'm gonna get started recording here. I do have some questions I wanted to hit just to answer these. So someone said high rate of tetracycline should be avoided in those less than 8 years old and pregnant women, second, third trimesters. Would this ring true for those breastfeeding as well? For instance, do tetracyclines transfer through breast milk of the mother into the baby, causing discoloration, skeletal deformities later on for the infant? My thought is yes, it can do that, but let's look it up just to be sure. Pulling up Lexicomp here with our doxycycline. This is the drug reference I use most frequently. Let's look for, so again, most drug references will have a section about pregnancy and breastfeeding that you can find there. So be around this section. The breastfeeding considerations. So doxycycline is present in breast milk. The relative infant dose of doxy is 6.14%. Let's see here. In general, breastfeeding is considered acceptable when RID is less than 10%. Yeah, so it looks like for the most part it does cross over, but it does not seem like, let's see, therapeutic use of doxy. Yeah, this would be one of those things where if they could avoid breastfeeding while they're on it, or if you could maybe use like an alternative agent other than a tetracycline, I would say that'd probably be preferential without me being able to read this verbatim right now. without getting into it. So I would be cautious with that. I probably wouldn't want one of my family members breastfeeding on a tetracycline same time for sure. So those are my thoughts on it. You can always look that stuff up though, right? Let's see, what does the plus minus for Pseudomonal coverage indicate? Only use a simple infection or otherwise healthy patient. So that's referencing the fact that it will not always have reliable coverage against Pseudomonas, meaning that if you had someone who strongly suspected to have Pseudomonas, use a different fluoroquinolone. For instance, like use Levaquin instead. And then if cultures come back and it's like sensitive to Cipro, then yeah, you're fine to use it. Otherwise, you know, I wouldn't use that as a go-to in that situation there. So, even though penicillinase resistant penicillin drugs can treat MRSA, we prefer to use Vanco to avoid resistance. Correct? That is not correct. Remember, penicillinase resistant penicillins are useful to treat MSSA. They do not treat MRSA, right? So in those cases there, that's why Vanco is going to be your go-to in a lot of situations there. But you have other alternatives too, especially if you're thinking like outpatient oral use. You have things like clindamycin. You have things like Bactrim. You know, there are other alternatives that are out there than just Vanco. But most patients, if you had them sick enough to being admitted, or that they need to be admitted, and you were suspecting MRSA, Vanco is always a good one to start out with, just because it's most likely going to get it, along with any other gram-positive bugs that might be growing there. So yeah, so big distinction there. Penicillinase-resistant penicillins are anti-staphylococcal, but only MSSA. Okay, so very important distinction to make there. Someone said, can you do a brief run through of the dermatologic vehicles? Which ones would be most potent / permeable? Remember that the more, like the higher the oil or the fat content is of a vehicle, the better the staying power that it has, the more occlusive that it's going to be. And so that will help for the drug to stay in contact. That will help the drug to stick around for longer. That's what helps it to be a little more, not potent, but you know, just it'll have greater contact time, so better absorption. So for instance, like if you were to look at like say a lotion versus a cream versus an ointment, the ointment's going to have the highest oil content to it, so it's going to be able to stick around. Imagine like petroleum jelly or something like, or Vaseline. Like if you ever like rub that on your fingers, that stuff is greasy as all get out, and it's really hard to get off your skin unless you use like a soap or something to remove it. So those are going to help out with things being sticking around for longer and having better absorption. In terms of like permeable, that more has to do with getting the drug into solution and then applying it to the skin and assuming it's going to be able to permeate through the skin itself. So it has to do with lipophilicity of the drug and things like that. So for instance, like, you know, bacitracin, good topical antibiotic, doesn't have very good permeability, so it doesn't get systemic and cause issues unless you were, you know, using on like, you know, broken skin or something like that. Yeah, so those are the things there. The higher the water higher the water content, or if it's like alcohol based or something like that that dries very quickly, those are usually gonna be less occlusive. They don't stick around for as long, so that would reduce the overall, you know, efficacy, quote unquote. But from a patient compliance standpoint, they typically like those better because they don't leave that nice greasy feeling behind. It's not a nice greasy feeling, it's just a greasy feeling. So FYI on the quiz. So Blackboard is not like my go-to learning management software. In fact, I dislike it quite a bit. I'm used to using Canvas, which is much more intuitive, I think. But you guys are on Blackboard, so unfortunately the quiz turned out to be a bit of a boondoggle there. I noticed some of you haven't taken the quiz yet. I think it's due the 23rd at midnight, so please get that done soon. If you get a bad grade on it, it's likely due to Blackboard's fault. It's not yours. So if you're curious about if I'm going to correct those, like, yes, absolutely. Don't worry about that. I more care about, did you actually get the knowledge from that? Like, did you actually understand it? The glitch in the quiz is totally my fault in not understanding how Blackboard was going to handle matching. So that's my bad. You know, I'll try to fix it in years future. But it is what it is. But don't worry about your grade. Worry about you got the knowledge down, and I'll correct the grade to make sure it's reflective of what you did. So wanted to make sure you guys were not too concerned about that. I know as PA students, you guys are all, for the most part, pretty type A. And so you see a bad grade and you're like, it like crushes your soul to a big degree, which I totally get. But don't let this crush your soul because it's just a error on my part. So. Anywho. Let's get into it. Let's talk about ENT stuff. Let's talk about our ENT concerns. We're going to go over a lot of like kind of typical run-of-the-mill cold management kind of stuff. You know, we'll talk about some antibiotics we're going to be using here for ENT concerns, a lot of upper respiratory stuff. So fortunately, we've already covered all the antibiotics we're going to talk about here. So now I'm going to more focus instead of how they work more broadly in terms of just their mechanism and interactions, things like that. I want to talk about how we're going to use them specifically for ENT issues. So how to use, you know, amoxicillin for an AOM or acute otitis media versus how to use it for something like for instance, you know, sinusitis, right? So learning the differences here are going to be important. So let's start off with acute otitis media. Remember that in terms of causative organisms, you always want to know what your go-to is in terms of like what your top differential is going to be for bugs. And so, you know, when you have a patient coming complaining of, oh, my left ear hurts, right? You should already, or even if you haven't seen the patient, right? You just see on the board it says, you know, 4-year-old left ear pain. You should already be coming up with a differential in terms of like what could be causing that left ear pain. You know, is it cerumen impaction? Is it otitis externa, otitis media? Like you're already coming up with a list. But when you settle on something like being infectious, you also need to come up with a list of like what the most likely causative organisms are, because that's going to dictate what antibiotics you're going to be using here. So it's okay to think like, okay, AOM, I'm going to use this drug. But I'd rather you think like AOM is most likely to have these bugs, which is why I think these drugs are going to cover it. Okay. And so that way you'll have a little bit better intuitive understanding of like how you treat these diseases here. So frequently, you're going to find otitis media is viral in nature, but most often you're going to find, in a lot of cases, that there's going to be a bacterial component and a viral component. We can't do a lot about the viral component, unfortunately, but we can treat the bacteria. And the three main ones you're going to run into, and this is going to be a good list here for the rest of ENT that we're going to cover. You'll see these pop up over and over and over again, right? So strep pneumo, streptococcus pneumoniae, you're going to see H. influenzae, and then Moraxella catarrhalis. Those are going to be the three that you're going to see cause the majority of these infections here. And of course, etiology can change over time, you know, as more people get Haemophilus vaccinations and things like that. You can see those rates go down, but, you know, there may be unvaccinated populations you're dealing with and things like that. So don't worry so much about the dosing specifically. I'm just mentioning dosing because some of it matters in terms of like how we're dosing in regards to like why we go with higher doses versus lower doses, things like that. But I'm not going to ask you specifically, how is amoxicillin dose for AOM? Is it 90 mg per kilo per day, 45? I'm not going to do that, okay? So mainstay, most of the time, just go ahead and use a high dose amoxicillin for these patients here. It's most likely to get all three of those bugs we mentioned, strep pneumo, Moraxella catarrhalis, and H. influenzae. Could be other things that's causing it? Sure, but it's less likely, okay? And again, we're going off probabilities here in medicine. We go with what the most likely sort of thing is. And so what you're going to find is that we use high dose amoxicillin because the drug by itself at regular doses has a hard time overcoming strep pneumoniae resistance. So by going up with a higher dose, you basically can get higher above get above that MIC for the bacteria and actually adequately treat it, which is good. What we can do for patients that are more severe, or maybe they have resistant disease, is you can go ahead and bump it up a little bit by switching over to something like amoxicillin clavulanic acid. Remember, by adding in the beta-lactamase inhibitor, you can still help to overcome a lot of resistance there. The other thing, too, is if you had a patient who had maybe had a previous antibiotic within the past month, like a lot of these kids may have, a lot of kids may be coming in with like frequent ear infections. This predisposes them to more resistant bacteria, which is why you got to step up your game a little bit and go from amoxicillin to adding in the clavulanic acid there. So that's an important thing to consider there. If you have someone who's like a true penicillin allergy, like they have a rash and wheezing to penicillin, for instance, you don't want to re-challenge them with another penicillin because you can just trigger that reaction off. So in those cases there, you could utilize something like ceftonir, which is a third-gen cephalosporin, or something like azithromycin, which is a macrolide. Remember, ceftonir is very low cross-reactivity with a penicillin in terms of causing an anaphylactic reaction. So especially a third-gen, very low risk. So that's okay to use there. Some of the problems you're going to run into, though, is that there's a lot of resistance to strep pneumo to azithromycin, which may make it not appropriate. So you may need to kind of feel out your local area where you're working to see, you know, what are the resistance rates like. You know, most of these kids with AOM, you're not going to culture unless they have like, you know, active drainage happening or if they have like tubes in place or something like that. So you may not know because you're not going to culture the kid, but if you have general ideas of resistance patterns, like with an antibiogram or something, that can be useful there. Typical treatment time, 5 to 7 days, maybe up to 10 days, even depending on severity of disease. Just really depends there. 5 days may not be sufficient though for like really severe cases, right? Now, say for instance, you have the patient come in, they're complaining of right ear pain. You look at it, it's all inflamed. You can see fluids back there. I mean, it's just, you know what it is. You know it's acute otitis media. Now, let's say you start them off on amoxicillin and send them on their merry way. They call back in 3 days, or they come back to the office in 3 days, and they say, "Oh, it's still the same. It's not any better. They're still febrile. It's just they're still miserable. What are we going to do here?" In those cases, if they haven't had any antibiotics in the past 3 months or so, again, that shows that they're less likely to end up having a resistant bug. That's where we can, again, if they were on amoxicillin, bump them up to augmentin. Or if they were on augmentin, maybe bump them up to a third-gen cephalosporin. Or if they were on azithromycin, go with the third-gen cephalosporin. You're most likely going to be able to cover that, get over those resistances there for the most part, okay? Now, occasionally, you may see some patients can require parenteral therapy, so either IV, IM. This would be if for patients who cannot tolerate oral medications. And so, for instance, we've had cases where kids will come in like 3 days a row to the ER and get IM doses of Rocephin. Or you may be able to get away with like a one-time dose of bicillin, which is that intramuscular long-acting penicillin. However, I don't see this used too frequently because rates of failure tend to be a little higher with just this one-time dose there. So if you can get away with oral therapy, that's always going to be preferential. Okay. All right, switching gears, let's go to acute bacterial rhinosinusitis. The same bacteria are going to be here, but your rates of resistance are going to be a little bit higher, and you're also going to see causative organisms is going to be a little bit broader. Instead of just being those three, strep pneumo, H. influenza, Moraxella catarrhalis, you can also have other things like, strep pyogenes, Staph aureus, some gram-negative bugs can start to pop up here. And two, like the sinuses can be kind of difficult to penetrate, which is why the antibiotics that we're using are going to be a little bit different in terms of dosing and which ones we start out with is like kind of your go-to first line. And so the other thing too is that most of these cases of rhinosinusitis, they're all viral for the most part, right? But if certain patients meet the criteria that make it more likely that it's bacterial, then they are good candidates for antibiotics. In this case here, if they have symptoms for like greater than 10 days, or if they're, sick for like, a week, like 5 to 6 days, and then they get even sicker, it's like a resickening they talk about. Those are things that may lead you to think, yeah, this is more likely to be bacterial, because usually it starts off viral and then it becomes bacterial as sort of a super infection there. So anyway, so here we know that amoxicillin just really can't get in high enough concentrations in the sinuses to really do what we need to do. And so because we also have high rates of beta lactamase producing H. influenza, amoxicillin is not going to cut it. So instead, you can start off with augmentin and go ahead and add in that clavulanic acid there. That can be really helpful here. If you had someone who could not receive penicillin due to allergy, this is where you can get away with using a less ideal situation, using 2 drugs instead of just one, but it is what it is. Sometimes you could use clindamycin plus cefixime. So this way you're going ahead and getting a third-gen cephalosporin plus a clindamycin, lincosamide that's working. More of those gram-positive bugs there can overcome resistance like strep pneumo and things like that. That's good. That's all well and good. Or you could utilize by itself just a fluoroquinoline like levofloxacin can be reasonable there. Again, levaquin resistance is becoming more of a problem as time goes on. So, from a compliance standpoint, is levaquin easier to do? For sure. But, may not be reasonable. Remember who levaquin may not be a good option in. Like children may not be great because of tendon issues and things like that. So again, know your audience and try to pick which one might be best based off of that situation. I said, okay, a patient's coming in and they're 6 years old and they have all the classic signs of bacterial sinusitis and they have a penicillin allergy. Which one would be best? Levaquin might not be the best agent there. It might be the combination of clindamycin and something like cefixime be a good combination there because of mitigating side effects from like levaquin by avoiding it. Right? Treatment durations can vary depending on the population. Usually longer for kids just because of things like eustachian tube dysfunctions and things like that. It's just sometimes it's more difficult to clear those infections in a lot of cases. In terms of like symptomatic management. Things like saline irrigations, especially during that first week, can be helpful because it can help just kind of flush things out. And, especially if it's still viral, this makes patients feel a little better. Make sure, though, that they're not using like, random water sources. That are clean water sources. Deionized water is always a good option. If they're grabbing stuff from their detention pond, obviously not great. So, make sure they're using clean water sources for that. Now for acute pharyngitis, this is a case here where we don't necessarily care as much about the bacterial infection, but it's more so the secondary issues that run up here. And this is, again, more of a pediatric disease here. But we worry about things like acute rheumatic fever and some of these other suppurative complications that can pop up as a result of having acute pharyngitis not being managed here. So, and this is the case here. Someone comes in with a sore throat. They used to just get prescriptions every time for antibiotics. And that really isn't appropriate because mainly is viral. So we have things like rapid strep tests that we can do nowadays to see, is it show positive for strep, group A beta hemolytic strep, and if so, then you go ahead and give them a prescription for something. Now, if someone has a rapid strep test and is negative, you still run a culture because sometimes the sensitivity is not going to be perfect for those tests there, and so you want to make sure you go into the backup culture. And if it comes back positive, then you go ahead and just call them back and give them a script over the phone or something, or into the pharmacy. So the go-to here, because we don't see a lot of resistance from the group A beta hemolytic strep here, is amoxicillin is always going to be good as a go-to for the most part. If they could not tolerate oral, then you can always get away with using a single dose of that bicillin, that benzathine penicillin G. Recall here, though, that it's parenteral, it's an injection, painful. Some kids may be very needle phobic. So if they're able to take oral, that's totally fine as well. In terms of alternatives, if they had a true penicillin allergy, something like, first-gen cephalosporin, like Keflex, clindamycin, azith, or any of those would be fine. I'd probably just go with Keflex and just call it a day for the most part. All right. Now, let's talk about some otic antibiotics. So these can be useful for things like otitis externa. Sometimes patients can use these if they have like a ruptured TM for otitis media, or like a lot of my ENT docs will use this after patients have had tubes placed in order to prevent infection after surgery, things like that. Usually you're going to find a combination of an antibiotic plus a corticosteroid. So for instance, here's Ciprodex, which is a combination of ciprofloxacin plus dexamethasone. So the benefits of doing that is that the corticosteroid can help to reduce inflammation, which is typically kind of making the patient feel very uncomfortable. It helps out with that. And then the antibiotic can go and kill off any of the bugs that might be growing in there. And so very helpful from that standpoint. Good from a patient standpoint because they feel better from the steroid, and then the bacteria gets eradicated as well. Keep in mind with eardrops that it's totally fine to use ophthalmic meds in the ear. You cannot use otic meds in the eyes. The eyes are very sensitive to things like tonicity and pH and all things like that. So you don't want to go ahead and just put an eardrop in the eye because it's going to irritate and sting very badly for the patient. On the other hand, though, you can put eye drops into the ears and it's totally fine. The ear does not really matter. It's not so sensitive of an area. So sometimes we can get around shortages. Sometimes if it's an insurance issue and patients can't pay for a drug, we can sometimes use a cheaper ophthalmic version, and that can be very beneficial to them. But in terms of just specific otic antibiotics here, you can see ciprofloxacin by itself. You can see Cipro combined with that steroid here, dexamethasone. Ciprodex, this is pretty expensive, even though it's a good drug. A lot of people use it. It's very expensive if patients don't have insurance, so it's not one that we will recommend if they have issues with payment. Here's one here called neomycin, polymyxin B, and hydrocortisone, so called cortisporin. So this one here, now you have an aminoglycoside-like antibiotic. You have polymyxin B, which is sort of in its own class. I think we talked about that briefly in the derm section. And then the steroid of hydrocortisone there. So still getting the same benefit as Ciprodex, usually a lot cheaper for the most part. Now there's some caveats why you might want to be cautious with something like cortisporin. Neomycin tends to carry a little bit higher risk of causing sensitivity than other drugs in the ear, especially. So you can end up causing like causing a dermatitis there in the ear, which may worsen inflammation than what the patient had in the first place, which is not great. And then if a patient has a ruptured TM, if any kind of opening in the TM, you cannot use polymyxin. Because that can get into the cochlea, it can cause damage to the hair cells there, so you do not want to use polymyxin if you have a ruptured TM. Okay, and then ofloxacin by itself can also be used occasionally. Sometimes what we'll do for patients who have like insurance issues is we'll give them the cheaper ofloxacin and otic, and then we'll give them ophthalmic dexamethasone. So that way they can kind of get the same benefits as Ciprodex without having the high price tag on that. As I mentioned, neomycin, think about hypersensitivity. Polymyxin B, think about the ruptured TMs, or if they have like tubes in place, that can cause hearing loss. So don't do that, okay? All right, talk about a few ENT antifungal medications here. So first off, we have something like ketoconazole. Sometimes you can see these used for like topical issues, or you can use it for systemic purposes by taking orally. These basically work by inhibiting the fungal cell wall permeability. It actually inhibits fungal CYP450. P450 is really necessary for the fungus to develop its cell wall by producing ergosterol. This can inhibit that. You'll typically see this used topically a lot. We mentioned it, I think, back in the derm section, being used for like diaper rashes and things like that. Occasionally, you can see it used for more systemic fungal infections if you had ENT issue along with that. Keep in mind, though, that systemically, there's a lot of side effects associated with it. So things like QT prolongation that can happen there. We talked about that with like macrolides and fluoroquinolones previously, in a ton of drug interactions, right? Being able to inhibit 3A4 in the fungus, it can do that to us as well, leading to a lot of drug interactions. So this one you probably want to hold off on unless you had a really significant fungal infection, more so like in immunocompromised patients there. Now, nystatin you're going to see used much more commonly. This one's neat because it actually does not get absorbed orally at all, or systemically when it is taken orally, meaning that I could have a patient that can drink a whole bottle of this, and you're not really going to see anything other than some GI side effects because it just doesn't get absorbed systemically. So what does that mean in terms of benefits for us? Well, it means that I don't really have to worry about systemic side effects, right? And it works pretty well for mucous membrane fungal infection. The main thing you're going to see this used for is for thrush or oral candidiasis, right? There's a few people who are more likely to develop this. And again, if you ever see someone with thrush, you can look up pictures. They have those plaques, those white plaques in the back of the throat. That's all candida sitting there growing. And so you see this more in patients with a compromised immune system, either due to like HIV/AIDS or chemotherapy, or they may have asthma actually. And we'll talk about this in the pulmonology section later on. But patients who are on inhaled steroids, remember, steroids can cause immunosuppression because they're anti-inflammatory. You can actually find that by suppressing the immune system locally, right there in the back of the throat, as they're inhaling these steroids, you can cause thrush infections. So this is a really good patient counseling point for patients taking inhaled steroids. They need to go ahead and rinse their mouth out afterwards and gargle some water to get rid of anything that might be growing there, get rid of any extra drug that might have deposited in the back of the throat. But for this, if they do develop thrush, then they can go ahead and take that for. So your question got me off track. But they do have thrush. You can go ahead and take in a nystatin oral suspension. They can swish and swallow, swish and spit, and that's totally fine there. Page asking, is ketoconazole no longer FDA approved? I think it's still FDA approved. I could be wrong. Look. Do live fact checking here because I don't want to be. Still. This one looks like the oral is sometimes. You may only see like generic varieties that are available here. It's looking like topically though, certainly we still use it quite a bit. Yeah, so you'll still see some topical varieties that are out there for things like diaper rash and things like that. Systemically, you don't see it quite as frequently, but like just mention it for completeness sake there. So yeah, it looks like it's still available. You know, again, nystatin cream, or I'm sorry, ketoconazole cream, things like that. You can certainly see. So. Anyway, getting into systemic antivirals. So there's a lot of ways you could affect a virus from replicating. And again, when I'm talking about viruses for ENT purposes, I'm not talking about like the typical rhinoviruses or adenoviruses and things like that you get. We can't really do a whole lot with those, mainly because we just don't have any good therapy for it. And most of the time, it's just all supportive care for those patients regardless. If you have someone who's like herpes simplex or herpes zoster or something like that, that we can do some stuff for. And so we'll talk about a few drugs we can use for that case. And again, it all depends on where you're going to be working at within the viral life cycle. We'll talk a lot about this when we talk about HIV meds and things like that. I want to focus mostly on things you're going to be working though for things like herpes simplex, varicella zoster, and cytomegalovirus. These are the main disease states I want to talk about here. I think we're talking about ENT stuff, so talk about things like cold sores and shingles and things like that that could be affecting the patient. Now, the way these drugs are going to work is they're what they call guanine analogs. And if you're familiar with DNA, which hopefully you should be, guanine is one of the nucleotides that gets incorporated into our DNA. It's just one of our genetic materials. If you notice here, these look a lot like guanine. But what happens is they actually get incorporated into the viral DNA, and they are lacking that sugar molecule, that sugar backbone, right? Part of that deoxyribonucleic acid. It's missing that sugar backbone. So even though it gets incorporated into the viral DNA, the virus cannot put anything else on after that. It's missing that sugar backbone. So basically, it acts as what they call a chain terminator. As soon as it gets added onto the DNA, no further DNA can be added downstream of that. So if a virus can't make new DNA, then it can't make new viruses unless you inhibit the viral replication. Okay, that's essentially how these are working here. There's a couple we'll talk about, acyclovir and valacyclovir. Valacyclovir is a prodrug that gets converted into acyclovir when it's taken orally and gets converted through the liver. Okay, this is done because it helps out with bioavailability pretty significantly. Valganciclovir, you're going to see this used less commonly, but this is more often seen in patients with like severe immunocompromisation, HIV, they develop cytomegalovirus or something. You may see valganciclovir or ganciclovir being used here. We don't like these as much in immunocompetent patients because there's a lot of side effects associated with these, as we'll see in a little bit. But again, valganciclovir is just a prodrug of ganciclovir. It just helps out with bioavailability. Okay. So acyclovir, you're going to see this used all the time. Valtrex or valacyclovir, again, you're going to see it used quite frequently. As I mentioned, it gets incorporated into the DNA, but the DNA cannot elongate it any further. So it causes DNA damage enough where the virus just can't not replicate. Okay. Acyclovir, you're going to see here used a lot for things like herpes simplex, varicella zoster, and you can look at the bioavailability between these two here and see that how valacyclovir has like a 70% bioavailability versus just 22%. So basically, I need less drug in order to get high systemic levels of valacyclovir than I would acyclovir, just because more of it gets processed to the liver, gets turned into acyclovir, and then now it's working functionally. Now, on the flip side, though, you'll never see IV valacyclovir because I don't need to worry about first pass metabolism. And again, IV stuff is 100% bioavailable anyway. So if I needed IV acyclovir, that's what I could just do, just get that straight. Now, you want to be cautious here, especially when using these because it causes a lot of side effects, a lot of issues here. And a general rule of thumb is that with treating viral illnesses, the sooner you start, the better. That sounds kind of like, well, no duh. But with viruses, you're going to find that with starting within 24 to 48 hours of symptom onset, that's really the sweet spot for helping to get duration of symptoms shortened, to eradicate the disease faster if possible. Herpes is herpes, right? It's going to stick around for forever for a lot of patients. What you can find is that the sooner the patients have symptoms, they start taking meds, the better it's going to work. So for instance, here with chickenpox, you have to take within the first 24 hours. Otherwise, it doesn't really do much to help shorten the acute illness. Okay. A lot of times it's not going to be, curative therapy. It's just really to help shorten symptom duration, help you keep outbreaks under control, things like that. So some downsides to the from that standpoint. The other thing too is some important points for counseling is you want to make sure they maintain good hydration while taking these. The main reason for this is because acyclovir and valacyclovir have a tendency in the kidneys, if they're not really well perfused, there's not a lot of volume, they can have a chance to precipitate out, and those little crystals, when they precipitate out, can cause interstitial renal damage. So if you hear like interstitial nephritis, that's one reason why that can happen there. And so by making sure patients are having good oral intake, that can be helpful to make sure the kidneys are kind of flushed through and get rid of that drug a little bit faster. So that's one thing to look out for. The other thing too is that from a CNS standpoint, you do worry about things like seizures potentially. This is more for patients who have really poor renal function and can't clear it. You can have altered mental status, more so like in elderly patients and things like that. So you want to watch out for that. And then you can have some degree of bone marrow suppression. This makes sense too, because of the fact that it does, basically suppressing DNA production of the virus. There's a little bit of cross-reactivity with our DNA, so you can potentially see some suppression of the bone marrow by preventing our cells from producing new DNA and replicating. Usually really fast-acting or fast replicating cells are affected here more often, so that includes things like the bone marrow, with the GI tract, things like that, right? Acyclovir and valganciclovir are more frequently used for like immunocompromised patients, or patients who are immunosuppressed due to medications for transplant purposes, who have developed cytomegalovirus. These drugs work exactly the same as acyclovir. They just have we use them more so and reserve them for cytomegalovirus because it's a very severe viral infection if they get it. High morbidity, mortality. The problem though is the side effects are a lot worse with these drugs too. So we try not to use them unless we absolutely need to. Neutropenia is much more common. Thrombocytopenia, that's that bone marrow suppression we mentioned there. And then also the CNS effects tend to be more common here as well. A lot of patients have to stop taking it because the side effects are so bad. Okay. So a little bit worse drugs. You're not going to use it for your run-of-the-mill patients, with a cold sore or something like that. But acyclovir could be used as an, alternatively there. Next, let's talk about influenza. Not a whole lot of drugs in order to treat this. I want to talk about the one that we use sort of most commonly, but this is oseltamivir or Tamiflu. This is going to have good activity both against both flu A and B. Hopefully, you're all going to get your flu vaccine this year. I just got mine yesterday. I'm not feeling too sore, but hopefully it'll help keep me protected. And generally, this is the time frame where we start to get it. So like September, they start to get the vaccine out there because flu season is generally from like October to March, but it could even go longer depending on how the weather goes and all of that. So fortunately, no activity against coronavirus, but at least it works against influenza A and B. Basically, this drug works by preventing this enzyme called neuraminidase from being able to cleave off new budding virus. So before the virus can bud off and go infect another cell, it needs this enzyme in order to do that. So this is prevented by the actions of Tamiflu here. Now, again, this is where time is critical. So it has to be started within 48 hours of symptom onset. If someone comes in and they're feeling miserable and they're achy and they're febrile and it's been 72 hours, Tamiflu is not going to do a whole lot for them. There's really no reason to prescribe it. And if anything, it worsens resistance over time. However, there are some exceptions to that, right? So there are some people who, if they get sick with the flu, are more likely to have bad outcomes. And so even if it's been greater than 48 hours, the downsides of using Tamiflu in those patients are relatively minimal. And there's only potential upside to it. So it's reasonable to go ahead and give it, even if it's not going to be the most effective. The risk for them, having bad outcomes is outweighed, or it outweighs the lack of efficacy from the drug itself. So go ahead and do it anyway. So who are those patients? Typically, those who are going to have compromised immune systems, either due to age, so like if they're less than 2, they're greater than 65, if they have chronic conditions like asthma or like diabetes, a heart disease, things like that, or if they're immunocompromised, especially if they're sick enough to be admitted to the hospital, just go ahead and give them the Tamiflu because chances are they can benefit if they're in any of these any of these categories here. But if it's like a run of the mill, like 26-year-old with no past medical history comes in with 72 hours of flu-like symptoms and he tests positive for flu, no reason to give them Tamiflu. It's not going to do you any good, right? They'll be asking for it, but you say, well, it's not going to be effective. It's not going to shorten your symptom duration. It's not going to do anything for you from that. Okay. You can see here, is an orally available medication. I only show you this to give you a sense for like the dosing here. Some of these, a lot of things are dosed by weight specifically. Here's an actual case here where it's actually dosed by the weight breakdown of the patient. So instead of saying like 3 mg per kilo per dose, like it would for like someone who's greater than 2 weeks, but they're still an infant. For a lot of kids, it'll just be like, okay, if they're between 15 and 30 or less than 15 kilograms, you do this. If they're between 15 and 23, so some of you get a feel for this if you're prescribing it commonly in your patient population, depending on who that is. Okay, next over antipyretics. So these are going to be good for treating fever. We have a couple options here. So we have our salicylates like aspirin. It can be useful. Again, by blocking the activity of cyclooxygenase 1 and or 2, you're going to be able to get decent antipyretic activity. We talked about aspirin in terms of its use for antiplatelet activity. Now we're using it more of its anti-inflammatory activity here, right? Remember, we're talking about dosages probably a little bit higher than what you would see for prevention of platelet aggregation, where you could get away with like 81 milligrams a day of aspirin. For that purpose, here we're going to be shooting up higher, so maybe like between 325 to 650, maybe even to a gram, as we're kind of getting into the sweet spot of that antipyretic analgesic sort of activity here. And remember, fever is not a bad thing, right? Fever is a normal physiologic response to help your body fight infection. A lot of people feel miserable though, and so if they're feeling miserable, it's fine. Go ahead and treat them. In terms of pediatrics, you're going to find a lot of parents who are fever phobic. I'm saying that 10 times fast. They are very worried about their children developing things like developing things like, febrile seizures, things like that. So it's very unlikely to happen, right? Treating that fever is really just for patient comfort more than any. Okay, so just keep that in mind as we're talking about the different agents here. Savannah's asking, so just to clarify, so give Tamiflu within 24 hours of onset or symptoms, or if immunocompromised, don't give it if no underlying conditions or it's been more than 48 hours of symptoms. So going back to Tamiflu, so if someone comes in, so let's say you have a healthy individual, healthy 25-year-old coming in, and they test positive for flu, and it's been 24 hours of symptoms, less than 48 hours, give it to them. They're fine to get it. If they are greater than 48 hours from symptom onset and they fit into one of these categories, then you can still go ahead and give it to them. If they don't meet either of those, less than 48 hours or into one of these categories, then don't give it to them. That makes sense. If not, let me know. I can clarify that further. So anyway, aspirin, again, worry about the bleeding risk, worry about using it in pregnant patients. And obviously, this is the other big thing. This is going to limit its use a lot as an antipyretic, and rarely are you going to be seeing aspirin being used for antipyretic purposes here, especially in kids. Worry about the Ray's syndrome. I think we mentioned that briefly before. But basically, if a kids are having a viral illness like chickenpox or something like that, you're increasing the risk of Ray's syndrome with aspirin. And again, it's only with salicylates, not with NSAIDs and acetaminophen. So this is where you want to worry about this, and this is what limits its use. But older patients, an adult, they can use aspirin for fever, no problem. Just be aware of those side effects you can see with that. And again, this is why we worry about Ray's syndrome. It can have pretty high mortality rates if not caught and managed early. And a lot of those symptoms look a lot like the flu, right? They look like, cold-like symptoms. So because of that, it's hard to identify. So for children with fever, I'd probably stay away from the aspirin if at all possible. Again, it's kind of these 5 stages they go through. Make sure you're warning patients, make sure you're educating them, even if they never thought about giving their kid aspirin, which I don't think a lot of parents do nowadays, but make sure you're educated on not doing it. And note here that it's not just everything you think about necessarily has aspirin in it. So for instance, like Pepto-Bismol is bismuth subsalicylate. Actually has aspirin in it, a salicylate-like product. And we use Pepto-Bismol a lot for GI upset and stuff these kids may be having as well. So definitely watch out and avoid that if at all possible. Again, how do you educate patients on how to treat fevers and things like that? Again, take the fever. If the fever is over 100, a lot of places say 100.4. I think that's 38 degrees centigrade on the nose there. Keep in mind, if a fever is not contained to less than 102, that's probably when you want to start to follow up, right? But, a fever of 101, 102, perfectly fine. Your body can handle that, no problem. It's when you get up to 107 and stuff is when things start to denature and you get into some big issues with that. But make sure they're drinking plenty of fluids to stay hydrated because it could be sweating more. And typically, if the fever is going on for more than 3 days, that's when they need to think about following up, right? Again, they can be self-medicating all day long, but eventually there could be something else going on there they need to get managed, which is why we usually give them about that 3-day period there. Obviously, the pain getting worse or lasts greater than 10 days, you have them follow up. Make sure they don't take aspirin with any other NSAIDs, because again, these will be working via the same mechanism. You won't get any additional benefit, but you may get more side effects from it. Then, of course, if they're taking anticoagulants, you might want to avoid aspirin because of that platelet dysfunction, but they may already be required to take it anyway, depending on the situation. Okay, so switching gears, let's talk about some of our over-the-counter NSAIDs. I'll talk much more in depth about NSAIDs when we talk about pain management purposes, or for their use as pain management drugs. I want to focus on the over-the-counter ones that we have available to us that are used for, a lot of aches and pains and typical fevers you run into from an outpatient basis here. So first off, we have Motrin or ibuprofen. Here you're going to see it has several uses being an NSAID, so a non-steroidal anti-inflammatory drug. It's anti-inflammatory, it's analgesic, and it has antipyretic properties here. So if someone stubs their toe and their toe's sore, take Motrin, it's fine. They're feverish, take Motrin, it'll work. Here you're going to see that it works by reversibly inhibiting cyclooxygenase 1 and 2. Keep in mind that's different than what we saw with aspirin, which is an irreversible inhibitor. This stuff only works while it's actually in the system at that time. And by decreasing that prostaglandin synthesis, it decreases a lot of those inflammatory cytokines that cause fever, that cause redness and swelling and pain and all that sort of stuff there. And so again, what do we use it for? Fever, mild, moderate pain. Most people have probably taken ibuprofen at some point in their life, if I were to guess, right? Typically this drug is used, most of the over-the-counter varieties come as just the 200 milligram capsules or tablets, however it's coming for you. Usually few 6 hours, 4 times a day is generally the most frequent you'd want to administer that. In terms of side effects, the things I'd like you to watch out for can include things like gastric or duodenal ulcers, perforation, and bleeding. This is a big one. The prostaglandins that are normally formed, one of the things they do is they help to protect the stomach. Normally your stomach is producing acid that keeps the pH at like a pH of 2. And if it were to come into contact with your stomach lining, I think I'm going to have a sneeze here in a second, so hopefully I'm going to blow out the microphone. Excuse me, I apologize. Action into my lectures, I guess. Anyway, so the stomach acids that you produce can easily chew through your stomach if given enough time, but we have a nice gastric protective barrier made up of mucus and bicarb and things like that. And what stimulates production of that barrier is prostaglandins. That's one of them. Acetylcholine does that as well, but prostaglandins. If you give people an NSAID and you decrease prostaglandin synthesis, you then decrease the ability to produce that barrier. You do that for long enough, eventually that stomach acid can eat its way through to the stomach and actually cause an ulcer, or it could even cause a perforation and then bleeding. So one of the number one causes for gastric ulcers in the world is NSAID use, right? The other one's probably H. pylori. So if you have one of these cases here, you might want to avoid using NSAIDs, especially from an outpatient basis here. And again, patients may be self-medicating with this stuff for years potentially, where they run into a problem before you even know about it. So you have to ask about over-the-counter meds patients may be taking in order to understand whether or not they're taking them or not, and that could be leading to their issues here. Also, you can tend to find that NSAIDs do not play well with antihypertensive drugs, and so they tend to have some effects on the kidney where they can lead to hypertension, they can lead to edema, fluid retention. This is more so in like patients who have comorbid conditions like CHF, hypertension, renal failure, things like that. So you want to be really cautious with that. And then this can acutely decrease creatinine clearance for some of those patients as well. So let me just show you that mechanism real quick, just so you kind of have an understanding. We'll talk more about this when we get into cardio later on. But if you imagine, if you guys are familiar with your kidney anatomy and physiology, if you imagine what a nephron would look like sort of at the beginning here, imagine we have an afferent arteriole coming into the glomerulus, and then you have the efferent arteriole coming out, what this would look like. And then you have this coming down, and then you have the renal tubule here, right? So you have the renal tubule, which is filtering out everything from the glomerulus, and then blood going out into the efferent arteriole. So blood's coming in this direction, and you have blood coming out of this direction. And then to show you, this is where the filtrate's going, this is where urine is being formed here, right? So what's happening with prostaglandins? Well, normally prostaglandins have what they call vasodilatory action here. So prostaglandins are going to cause this to open up. Prostaglandins, right? By dilating those vessels there, it allows for more flow through, right? Because again, they have a larger diameter, more flow can happen here. That increases filtration, that increases GFR, okay? Most healthy patients, if they take an NSAID, this is not going to be affected greatly. But if you have a patient, what's going to happen is if I introduce an NSAID and I get rid of those prostaglandins, instead what I'm going to see is I'm going to have vasoconstriction here. I've lost the prostaglandin. So vasoconstriction leads to a decrease in the amount of filtration happening, meaning creatinine clearance is going to go down. Okay, that can be a big deal for patients who have pre-existing kidney disease, and you want to be very cautious using NSAIDs in those patients. So if they have previous history of like ulcers, for a second here. I'm back. Sorry about that. So anyway, so like I was saying, if you were to have going down. All right, sorry about that. It looks like I'm back. So anyway, so by having someone who has pre-existing kidney disease, if we were to drop their creatinine clearance, that can lead to some big issues in terms of drug clearance and azotemia and all those sorts of things. So you want to be cautious with that. So my stream is going in and out there for a second there. Hopefully it'll get better. Okay. Now you've done checking out my awesome art skills there. Let's go on. Now in terms of interactions, I mentioned these don't play well with other antihypertensive drugs. So we'll talk about these when we get into cardio later on. But if you mix them with things like ACE inhibitors, if you have them with diuretics, all that can end up worsening your effects. You gotta be really cautious with those there. Some other drugs that can interact with too, like lithium and methotrexate. We'll talk about those at later dates. Just know they can increase levels and lead to further toxicity from those. So you gotta be really cautious. And of course, if someone's on a medication for bleeding, for instance, or to cause anticoagulation, this can increase your risk for bleeding. So you do want to be careful there. All right. So in terms of contraindications, obviously if they're allergic, you want to be cautious there. If they have a history of asthma, some patients are going to be more sensitive to this and could have asthma exacerbations being worsened here. It's a rare thing, but again, you want to be cautious. They have a history of like ibuprofen allergy. Chances are it's because they have a history of asthma that's worsened by taking things like NSAID. So watch out for that. And then of course, we also want to avoid it in kids less than 6 months. This has to do with undiagnosed cardiac conditions, that they have something called a patent ductus arteriosus, and they have a cardiac condition that makes it so that they need that PDA open. Things like Motrin can actually go through and actually close that prematurely. So because a lot of those kids may not be diagnosed yet because it just hasn't kind of reared its ugly head, we go ahead and just avoid using NSAIDs in kids less than 6 months. Okay, so NSAIDs, while good as anti-inflammatory, antipyretic, make sure you know who not to use them in. Okay, kids less than 6 months, people have a history of GI ulcers, especially if it's due to NSAIDs, things like that, you'll be really cautious with. Okay, some other ones you might run into include naproxen or Aleve. As a longer half-life, so typically that's dosed like once or twice daily. Those are the two big ones you're going to see over the counter. So naproxen, ibuprofen is NSAIDs. You'll find aspirin, which technically is an NSAID as well. Those are the three big ones you'll see there. So that's why I wanted to mention them here. Next up, we have Tylenol or acetaminophen. You're going to find here that if you're curious where the name Tylenol actually comes from, it actually has to do with the chemical name of acetyl para-aminophenol, so Tylenol. That's where the actual brand name of the drug comes from there, which is kind of, I wouldn't say interesting, but I think if you wanted to wow your friends with what you're learning in PA school, that could be one of those facts there. But in terms of mechanism here, notice that we don't fully know how it works, but it does work centrally up in the brain to work as an analgesic and an antipyretic. Note here, it does not do anything for inflammation. If you have someone who stubbed their toe and had a red, swollen toe that hurt, Tylenol is not going to help as much with that. It may help out with the analgesia portion of those signals being sent up to the brain, but it won't actually do anything to the inflammation at the toe. However, very good in terms of mitigating the effects of that pain, not for the inflammation, but also good as an antipyretic. So this is used pretty commonly too. Big things to note with this is you don't have a lot of the contraindications like you do with the NSAIDs in terms of who can't receive it. But one thing you do want to be cautious of are patients who have a history of hepatic dysfunction, because that's the major organ toxicity you're going to see with Tylenol, is it can cause liver injury if you're taking too much of it. So for instance here, if you're taking more than 4 grams in a day for several days, that can lead to hepatic dysfunction, can lead to some pretty severe effects, and death in some cases there. That's why all of the warnings you're going to see on Tylenol bottles says, make sure you know this has Tylenol in it, this has acetaminophen in it, because we don't want you to take too much. Because there's so many combination products that are out there. A lot of cough and cold products will have acetaminophen in it, just because of, it's so ubiquitous, is so good for helping out with aches and pains and things like that, that's why I include it all. Anyway, but very well tolerated otherwise. Not a ton of side effects here, but beware if you have a patient who has a history of hepatic dysfunction, they're chronically abusing alcohol, things like that, this can increase their risk for damage there. So you do want to be cautious with that. Okay? No more than 4 grams in a day is a typical recommendation here. All right, those are antipyretic drugs. Now I want to switch over and talk about antihistamines a little bit. This will be a bit of a longer topic just because the actions of these drugs are so pretty broad here. But anyway, what is histamine? Well, we know histamine is one of those products that we release from things like mast cells. They are really helpful for producing a lot of the inflammatory response that we normally see as a result of allergy or something like that. And so that's where you get like the redness, the wheal, and the flare. And so this kind of goes into a lot of the actions that histamine has within the body. So things like, post-capillary permeability. That's why you end up seeing that, blood vessels will dilate and you get really edematous in areas that are inflamed. If you think about, developing runny nose and inflamed eyes and things like that, if you get, triggered by an allergen like dander or something like that. And so you can see here that, we have histamine receptors all over the body. We're mainly going to focus on the H1 receptors. H2 will become clinically important in the GI section later on. That's where they cause a lot of things like gastric acid production and things like that. But we're going to focus on the H1 receptors here because that's really important in terms of allergy. And you can see kind of different places where they're going to be working, including like causing decreases in blood pressure. That makes sense. If you see someone with like true anaphylaxis, they're typically hypotensive because it causes vasodilation to occur. You're going to see a lot of mucous membrane secretions and things like that that occur because of this. So anyway, so some of the things you'll see, again, as I mentioned, vasodilation, you're going to see mucus secretions, decreased smooth muscle tone in some places there as a result of that. So, and even bronchoconstriction, this can be really bad for patients with like asthma that can be triggered off by certain allergens. So for instance, if you have things like like pet dander, for instance, me really aggravates my allergies. So if I get around a new pet for the first time, chances are I'm gonna have a runny nose, might have an asthma attack, and all the kind of things that happen as a result of histamine being released there. So frequently, I'll take an antihistamine beforehand, and it prevents a lot of that from occurring. Okay, so when I give an H1 receptor antagonist, what I'm going to expect to see are going to be kind of two delineations here. I'm going to talk about the peripheral effects, and then I'm going to talk about the central effects. And so it's good to make sure you know the differences between those, because we'll have different drugs that more focus on peripheral, or have some drugs that do both central and peripheral effects here. So starting off, H1 receptor antagonists, what they're going to be doing is when they're going to help block smooth muscle contraction, for instance, like in the GI and the bronchial smooth muscle, they're going to end up seeing that will help to relax the bronchial smooth muscle, allow for easier breathing. It's going to block vasodilation, block secretions, itching, all those sorts of things are really helpful for managing a lot of those peripheral sort of allergic reaction effects. On the other hand, though, in the CNS, this is where we can get into some variety of effects here that may be useful or maybe not so useful, depending on the case here. What we're going to see is that not only do these drugs frequently block histamine receptors, they also have what they call antimuscarinic properties. And so we'll talk about some of those things we're going to do as well here. But sedation is going to be one of the major side effects of these drugs. I'm not sure if anyone's ever taken Benadryl before. Most of you probably have. But sedation can be pretty significant. Some people are really sensitive to this. 25 milligrams of Benadryl, even 12 and a half, and they're knocked out like all night, But you can see pretty additive effects with other things like CNS depressants, or if they're taken with alcohol. So make sure you want to educate them to avoid mixing with other CNS depressants, okay? Now, the sleep effects can be useful because it's actually marketed for that in some cases. So if you ever see like Unisom over the counter, that's actually a sleep aid that contains doxylamine, which is antihistamine. So it depends on the situation. If someone's like just feeling sick as snot, literally, and they're having a lot of rhinorrhea and itchiness and all of that, and they just need to go to sleep, but they're miserable, this could be really useful because it can help them sleep. It can help them to decrease mucus secretions and all those sorts of things that can help out there. Okay. Now, some people have excitation as a result of taking these medications. That is more of a result of either like children taking it, where they get what they call a paradoxical reaction, where you'd expect them to go to sleep, but they just get super anxious and they're bouncing off the walls and they're going crazy. And then in extreme overdose, you can also see a lot of excitation there. So again, it all is really dependent on the dose you can see with that. Now, there's going to be what we call first generation, second generation antihistamines, and it's important to note that second generation antihistamines do not really cause sedation. It's very low probability of sedation. You're going to find that they do that because they don't really cross the blood-brain barrier, right? Basically, the molecules are designed such that they cannot cross the blood-brain barrier. So they really only have peripheral effects. Second generation does not have central effects. First gen will have both central and peripheral. I'll show you what that looks like in a chart here in just a second. Some other benefits you're going to see with the non-specific or the first generation antihistamines working centrally in the brain is you can also find they have antiemetic actions. So they're actually good for things like motion sickness. They're good as antimuscarinics, meaning they decrease secretions. They can dry the patient out, especially having a lot of like postnasal drip and things like that. And some mild anti-serotonergic effects, which clinically is not going to come up too much. So I'm not going to focus too much on that at the moment here. Going back to those antiemetic actions, basically what we're seeing here is that based on their actions in terms of blocking acetylcholine on muscarinic receptors in the brain, and then also blocking the chemoreceptor trigger zone, or CTZ, they have really strong antiemetic actions here, which is really helpful. You'll see this recommended a lot for patients going on cruises and things like that. So for instance, like promethazine or Phenergan has really strong antimuscarinic action. Really good for, if you have like motion sickness, if you're going on a cruise, if patients are just extremely having a lot of secretions and they're nauseous. Promethazine is a really good drug, but it's also like one of the most sedating one of the bunch too. I recall one time when I was sick as a I was probably an undergrad or something like that. I was really sick. It was like snotty everywhere, and I was just miserable. And one of my aunts was like, "Here, take this Finnegan." I was like, "I don't know what this is." And she said, "Just take it; it'll be fine." And I think I slept for like 18 hours straight. It was probably the best sleep I've ever had, and I'll probably never get that back again. But the benefit with being is that I was super dried out, and it was much more comfortable. I could breathe better. Very good drug. Was not nauseous anymore. So, heck of a drug, but also super sedating. If I needed to go somewhere and drive a car, it just would not happen that day. So all depends on the drug, and we'll look at a chart that compares those in a little bit. Now, here's the thing I want to focus on a little bit. This is called anti-muscarinic actions of the drug. Again, by blocking acetylcholine on muscarinic receptors here, it does a lot of things that are helpful for allergies. So it will decrease mucus secretions. It will help to, manage a lot of those a lot of those allergic reactions and whatnot. I want to give you a mnemonic though that will help you to remember the side effects and the effects of anti-muscarinic drugs here. And so this is one. Highlight this because it'll come up over and over again. Whether we're talking about GI, we're talking about GU stuff, we're talking about behavioral health stuff, these anti-muscarinic drugs are going to come up over and over and over and over and over and over again. So I want you to know this because I want you to be able to anticipate what the side effects are going to be based off just hearing something is anti-muscarinic. You should already have a feel for what that's going to cause. This mnemonic will help. Okay. First off, blind as a bat. Right. So this means they're going to see that they're going to cause mydriasis. The pupils will dilate. They also cannot accommodate very well. So people will complain of blurry vision or photophobia because they have all that light coming in to their retinas, right? Mad as a hatter. This has to do with the CNS effects. Sedation at lower doses, but excitation, maybe even seizures at really high doses, okay? If anyone's curious, mad as a hatter actually comes from mercury toxicity. Used to see people who used to felt hats, but it's neither here nor there. Red as a beet. You can see vasodilation that occurs. The patients may get a little flush. Hot as Hades, meaning patients typically will feel hot. It has a lot to do with that vasodilation. Some people can even get febrile from this. Just depends on the situation. Dry as a bone is really important for our purposes now because it helps to dry the patients out. It decreases mucus secretions. It also decreases secretions everywhere. So it's going to cause dry mouth. It'll cause urinary retention. It slows down peristalsis, which means it can cause constipation. Huge one there, causing constipation. And then finally, the heart runs alone, meaning blocking acetylcholine on the muscarinic receptors in the heart causes tachycardia. Okay? So in the future, if I say, oh, this drug has anticholinergic, antimuscarinic properties, you should be able to point out and say, oh yeah, I know this is going to cause them to be blind as a bat, so they can't really see very well. I know it's going to cause them to be dry as a bone. Be able to internalize this and use it because it's going to come up over and over and over again. Okay. Anyway, what are our indications for our H1 blockers here? We're going to see that for allergic reactions mainly, we're going to see that whether it be an insect bite, drug hypersensitivity, whatever the case may be. You can use these for motion sickness or nausea and vestibular disturbances. This is more so the first generation drugs. Second generation, they don't work centrally, so they won't work for this at all. Over-the-counter sleep remedies or adjuvant role in anaphylaxis. Okay? The main uses there. As I mentioned, sedation, GI disturbances, antimuscarinic properties. These are all the side effects you're going to see with that. You may see some of these used topically, and it can cause some dermatitis, but it is pretty rare. But just know it's more to do with the dermatologic vehicle than anything else. All right, this is the table I want to get to. Don't worry so much about duration of action. I'm not going to ask you questions about that. But what I do want you to focus on are the differences between the first gen, second gen drugs. And then I want you to kind of notice the general feel for the various side effect profiles here, okay? What you're going to see here, we have a lot of these that are available over the counter. So for instance, chlorpheniramine, dimenhydrinate, diphenhydramine, you can find those over the counter right now. Meclizine you can find over the counter right now. So a lot of patients may be self-medicating with these. Things like hydroxyzine, things like promethazine, more prescription only. But overall, what you're going to find is that, yeah, they're going to have sedative effects to some degree. They're going to have antiemetic effects for the most part. They're going to have anticholinergic effects for the most part, right? So if you see a first generation antihistamine, you should be able to identify, okay, yeah, it's going to cause the patient to be sleepy. It's going to cause maybe some antiemetic activity, and it will help dry them out. It may cause constipation, cause tachycardia, right? Versus the second generation, which we have cetirizine, fexofenadine, and loratadine, which now are all over the counter. These used not to be the case. Back when I was in school, all of these were still prescription only. That was my age at all. Very low effect here in terms of sedation. Very low antiemetic activity. Very low anticholinergic effects, right? They're only working peripherally to deal with the symptoms of allergy, but they don't do anything for this the central effect. Only work peripherally. No, that's not to say that, you know, and always have one person always comes up that, well, I get really sleepy every time I take loratadine. Yeah, some people are oddballs, right? Some people are abnormal in terms of they don't act the same way as everyone else does. That's totally fine. I'm not saying you're abnormal if you feel that way, but I'm saying that, you know, you have a atypical reaction to a medication, and that's always possible. That's why I say, you know, it's very low, but it doesn't mean that they're not going to have no sedative effect. So, you know, if I had someone who's a truck driver and they need to drive for the next 18 hours cross state or something, I'm going to recommend a second generation antihistamine. I'm not going to give them a first gen because they're going to be too sleepy and they can get into a wreck, right? Those are things to note there. We do have one intranasal antihistamine, which is a Zelastine, which we'll talk about briefly here, but again, because it's only working locally in the nose, very little systemic effects, very little peripheral effects. It's just working in it. Okay, so Zelastine I mentioned there is working as an intranasal antihistamine. Most people, I honestly, you know, with the added inconvenience of using a nasal spray and the fact that it doesn't work for all the peripheral allergic effects, you know, you're better off just using something like loratadine or fexavenidine, something like that. Zelastine does not get a whole lot of use here, but it could be an alternative if some patients did not want to take an oral medication or limit systemic exposure. You know, with most intranasal medications, you know, things like bitter taste, epistaxis are possible just due to one irritating the nasal mucosa and also just postnasal drip, you know, getting it on the tongue and having some taste there. So it's pretty common side effects you're going to see with that. Typically with whenever you're applying intranasal medications, and I'll kind of mention this here and it applies to all the other ones we'll mention, is that first off, clear the nose out. Make sure that there's nothing that's going to be occluding the nasal mucosa from coming in contact with the medication there. You'll tilt the head down, and then you want to angle the spray away from the septum because you don't want to accidentally cause any sort of damage there to the septum. So point kind of away. You can use basically the opposite hand for whichever nostril you're using. That can help out with that. So using the right hand, the left nostril, and vice versa can help prevent the patient from jamming right into their septum there. And then basically don't have them tilt their head back because that can then increase that bitter taste and may get on the back of the tongue there. Make sure they're going to clean the tip of the bottle so that way they don't leave a bunch of gross cooties on there for later on. And then typically you want to separate out other nasal sprays. So kind of give time for the one to work before you kind of move on to the next one. Not a lot of patients are going to be multiple nasal sprays, so this is less likely an issue there. If they develop nosebleed, then definitely discontinue the med and have them follow up because it could be signs of could be mechanical injury, could be chemical irritation, who knows, right? That's why we want to have them checked out. All right, so then switching gears, I'll talk about some ENT corticosteroids. Now, again, corticosteroids are working much more powerful anti-inflammatories because they're working at the site of the nucleus to change transcription and decrease the production of inflammatory cytokines, decreasing degranulation of mast cells and all these different things, right? So really powerful anti-inflammatories. But again, we have to worry about the side effects that kind of come along with their actions, as we'll see there. Now, one way to mitigate systemic side effects of corticosteroids is by using them nasally. So this is a case here where it does make some sense for patients who have like allergic rhinitis, especially if it's seasonal or if it's year-round. These can be really helpful medications here. So things like beclomethasone, budesonide, flunisolide, fluticasone, mometasone, and then triamcinolone all are available to be used as an intranasal. A lot of these have gone over the counter in years past. One thing I want you to know, though, is really easy to get these mixed up with the inhaled varieties, which we use for asthma. And that's a common ordering mistake I'll see providers do, or I'll see even the pharmacy will make occasionally. Typically, the brand names are designed so that you know the difference. So, for instance, like with budesonide, it's Rhinocort for the nasal one, which Rhino makes sense, versus Pulmicort, think lungs, makes sense, or Flonase for the nasal one, or Flovent for the pulmonary one. So try to keep these straight in your mind, at least when you see patients and you're doing like med racks and stuff, to make sure you keep that separate, because you don't want to take down okay, you're taking fluticasone and you didn't notate whether it was nasal or inhaled, and patients may have both disease states, and that can lead to an error. So be cautious with it. Now, what do we use this for? Allergic rhinitis, vasomotor rhinitis, again, these take longer to work. So as opposed to an antihistamine, which blocks histamine receptors immediately, steroids do take time. It can take weeks before you really see the full effects of them kick in because they do work more slowly at the site of the nucleus, but it does take, they're more powerful, but they take longer to work. So that's one of the the downsides of the steroids there. But you can see, septum perforation here happen here. This makes sense because of steroids causing delayed wound healing, and this happens in the nose just like anywhere else. And so you can see that as a risk, even though it's relatively rare. Again, same recommendations in terms of how to administer, so nothing changes there. So you can kind of just refer back to the last slide when we talked about that. But sometimes you're going to find that nasal medications may not be enough, or they may be having systemic symptoms that require additional management. This is where we can sometimes do what we call it pulse dose steroids, where we may do like a 5-day course of steroids for certain patients who are having more kind of systemic inflammatory issues to help get things under control. I'm not going to talk about every corticosteroid out there, but I at least want to talk about a few that are common, used more like in the ENT sort of situation. So especially someone coming in with like really bad rhinosinusitis, and you're giving them antibiotics, but that pressure is just so painful, they feel miserable. Stuff like dexamethasone and other corticosteroids can be really useful here, right? So be cautious of the side effects are typically what sort of limits its utility. And, if you're doing 5 days worth, it's probably not going to be a big deal for patients who are like relatively healthy. It's the people with all the comorbidities where you run into issues here. So if they have a history of like CHF or hypertension or edema, this is going to worsen that because you're going to be holding on to more fluids as a result of some of the mineralocorticoid, the aldosterone-like effects of the corticosteroids. Glucose intolerance, which is bad for your diabetic patients. So imagine if you had someone who is like, say you had like insulin dependent diabetic, right? So someone who's taking insulin to control their glucose, and you put them on a steroid, let them know, hey, your readings are going to come back a little bit higher. You may need to adjust your insulin dose to account for that, right? These things you want to let the patients know about to expect, so that way they can adjust accordingly, right? Other things you can run into include things like hirsutism, Cushing-like symptoms, potassium loss, sodium retention, right? This is why you see a lot of issues with blood pressure, even tendon rupture as a result of like impaired wound healing, things like that. Again, not a big deal if you're taking like 5 days worth. It's more of the chronic use of these drugs where you see more of these issues become more prevalent and more common. Patients with history of like glaucoma, this can worsen their intraocular pressure, so you want to be careful there. Increased cataract formation, things like that. And then overall, they will decrease your resistance to infections because, again, they're anti-inflammatory. They predispose you to viral, fungal infections, things like that. So be cautious there, especially if you're using more than a week's worth of therapy. A lot of side effects or a lot of drug interactions you can run into this, most of which are going to be pharmacodynamic interactions where these sort of mitigate the effects of other drugs and how well they're going to work. So for instance, like if you're on an antihypertensive drug, steroids that raise blood pressure are probably going to make your antihypertensives less effective, right? Those are things you want to consider there. Again, we mentioned contraindications. They already have like a systemic fungal infection. This is not a case where you want to weaken the immune system any further. You may want to make sure and avoid that. And in terms of patient education, this is an important one to remember that the body works off of like a lot of negative feedback loops. And so one of those is which is between your hypothalamus, your pituitary gland, and your adrenal gland, right? Your things like ACTH, they'll stimulate release of things like cortisol from the adrenal glands. Remember that if you're taking exogenous steroids, that's working as an influence on that negative feedback loop. The body detects it has enough steroids around, so it says, okay, I don't need to produce any more, which can cause that adrenal insufficiency if they're on it for more than a week. So if they are on it for more than a week, then you want them to slowly taper off of it. So maybe, take maybe on their full dose steroids for like 2 weeks, and then you have them taper off for 1 week, right? So slowly decrease the dose throughout that week in order to prevent adrenal insufficiency. Okay. Prednisone is just another one in the same category of corticosteroids. Main differences between these being duration of action or relative potency. So as an example, if I was dosing a patient with prednisone for an allergic reaction, I might do like 1 milligram per kilogram up to like 60 milligrams versus if it was with dexamethasone, I'd use like 0.6 milligrams up to a max of like 16. So dexamethasone just being more potent because I need less drug to get the same effect, right? You don't have to memorize those numbers there. I'm just showing you that some of the differences. Prednisolone is a liquid formulation you're going to run into. Prednisone is a tablet form, so prednisone actually gets converted into prednisolone in the body and works the same there. Same risk for side effects, same risk for weakened immune system, all those things there. Same risk for adrenal insufficiency. They're on it for more than a week, so you got to taper, things like that. All that's going to be the same in this category here, but I just want to give you options, right? So if you see a test question, prednisone's there, be like, oh, I don't even remember what prednisone is. I only know dexamethasone. I I don't want you to get into that trap there. So be able to recognize these as both as corticosteroids. They're really going to have the same profile in terms of adverse effects, mechanism, all that's the same. Okay. All right. I just want to talk about a few ENT decongestions. I'm on track, it looks like, to finish on time, which is fantastic. This is hour 4 I'm going on talking today, so right here in my voice. But anyway, so let's talk about some drugs that can help to decongest patients nasally. This is going to be a drug called oxymetazoline or Afrin. Most people probably heard of Afrin before. It's a common over-the-counter med. This is going to be an alpha agonist, and so what that means is it's going to constrict the blood vessels in the nasal mucosa when you apply this intranasally, and that's going to allow for decreased leakage out of those capillaries. Is going to decrease edema, the swelling, all of that. So decreases the rhinorrhea that patients will experience by constricting those blood vessels. It's very good at what it does. However, though, you're going to find there's some downsides there. By chronically activating these alpha receptors, you're going to find that they get overstimulated, and so they then downregulate. So if you had 10 receptors that were available to interact with, maybe it goes down to like 3. Okay. What happens though is if you stop taking the medication after like 3 or 5 days or so, when that downregulation has sort of taken place, now all of a sudden you only have 3 receptors to interact with normal things that would activate them. Things like norepinephrine and epinephrine that would activate as alpha receptors. That's just not enough activation anymore. And so what happens is they get a lot of rebound nasal congestion, right? So and oftentimes it's even worse than what they were experiencing beforehand. And so it's called rhinitis medicamentosa, where basically they had this rebound nasal congestion as a result of stopping the use of this medication here. So that's why we only usually will recommend no more than 3 to 5 days max. For instance, at our hospital, if you get put on Afrin, it automatically falls off of the profile at day 3, right? We do not want this to happen. What happens though if people are on it for longer than that is they basically develop a physical dependence on it, and so they need to keep taking it, otherwise this congestion is going to come back. That makes them miserable. You can titrate off of it slowly. That is something you may have to work with patients on, but a lot of people will just stay on it, and I've seen some people who have just been on it for years, right? So be cautious with that. The other thing too is that while it's working locally in the nose, you can still see some systemic effects and can raise blood pressure. So this may not be the best thing for someone with like really bad uncontrolled hypertension, but if it was like someone who, you know, was on meds and their blood pressure is totally fine, under control, this is not going to be a bad option for them. It just may raise their blood pressure a little bit. Okay. So again, no need to talk about anything different about the nasal administration. It's the same as all the other ones have been. From a systemic standpoint, though, if patients didn't want to take a nasal spray, for instance, they could use something systemic like pseudoephedrine. Erica's asking, is there a way to come off of it once you have been on it for a long time? Yeah, it's all about titration down. Just anything you can develop physical dependence to, whether it's opioids or benzos, alcohol. It's all about slow titration off. So, you know, if they're using it 3 times a day, for instance, maybe try spacing out, only using it 2 times a day for a couple of days. See how that works. You know, they may have some increased congestion, but it won't be as bad as if they stopped cold turkey, right? And go down slowly. Then, you know, do that for like a week, and then maybe go down to 1 spray a day for a week, and then try to come off. Things like that can help sort of mitigate the withdrawal sort of effects. You can see. So anyway, so pseudoephedrine, this is a systemic med, take orally typically. Now, most of you probably are aware of pseudoephedrine not being available, you know, on the actual store shelves when you go out there looking at the over-the-counter section. But what you'll find is actually behind the counter, and that's because there was legislation put in place due to worries about people making methamphetamine out of pseudoephedrine as a precursor, which is definitely a thing. It can happen. It was probably not as rampant as a lot of people would think, enough to make the whole drug more difficult to get. But there's limits on how much you can buy and things like that. So I'll talk about you know, an alternative here in just a second. It doesn't really work as well. But basically what this is going to do is that instead of just working in the nose, it'll work systemically as an alpha agonist to constrict blood vessels, especially in that nasal mucosa. Pretty handy from that standpoint. It can also be useful for things like eustachian tube dysfunction and whatnot, to kind of help clear those out a little bit, to allow for better airflow and whatnot. Keep in mind, though, that you're going to see these systemic effects that occur here. So you can see things like tachycardia, hypertension, and headache. So I'd be really cautious in using this with someone who was not well controlled on their blood pressure. Because this can worsen that, and some people have stroked out before because of this. If they are well controlled on their blood pressure medications, make sure they're taking readings at home to see if it's going up while they're on this, and make sure that if it's, you know, on the threshold, say if it goes up by this much, stop taking it, you know, because you want to make sure that blood pressure is under control, does not go too high. Now, what you'll see frequently on pharmacy counters or on the shelves, with the other OTC meds is something called PE. Um, if you see like Sudafed PE, it stands for phenylephrine. When taken orally, this stuff is like pretty much nothing. It's pretty much like placebo, basically. So it does not work for many people. Um, so if you want someone to actually get their sinuses decongested or decongest the nose, have them just go and actually talk to the whoever is managing that, whether it's the pharmacy, whether it's somewhere else, get the actual stuff that contains pseudoephedrine, because phenylephrine just is not going to work all that well. Using IV, it's a totally another story. It's really good as maintaining blood pressure, but it's not what we're talking about. All right, next a few antitussive and expectorant medications here. So first off, cough. What is cough? Basically, it's a reflexive response that our lungs will demonstrate when we have like a chemical or some kind of mechanical irritant. Basically, you have these receptors, usually stretch receptors or chemical receptors, that when they are triggered, they will send off a signal through the brainstem, and that causes this reflex pathway. It's all modulated through the medulla. And basically, we have that deep inspiration, close the glottis, contract the chest wall, you get a huge amount of pressure, and then hopefully whatever was causing irritation is coughed out. And if you can see the pressures here, like 300 millimeters of mercury, 500 miles per hour, they estimate for some coughs. So pretty significant. Of course, imagine someone not wearing their mask and coughing all over you. You can see how spread of disease happens pretty easily. Um, why do we care about this? Well, because it's bothersome. It causes insomnia. It can cause exhaustion if you can't sleep because you're coughing all the time. Keep in mind, like, what is causing the cough? Is it postnasal drip? Because maybe at that point there, they need something that kind of dries them out, like an antihistamine, for instance. Um, but overall, we want to try to decrease the number and severity of coughing episodes and try to prevent any complications thereof. There's a few meds here. Some of these are over the counter, some of these are not. I'm not going to quiz you specifically on the test, like which one of these are over the counter. Like, I don't, you can figure that out. You'll learn that as time goes on. I just want you to know what your options are in order to treat a disease, know which ones are going to be best for your particular patients. Um, First off, we have one here. This is a prescription-only product called benzonatate or Tessalon. It's called Tessalon Pearls. Again, you can see these look kind of like maybe fish oil or some kind of vitamin E capsule or something like that. But basically, what it does is it works to anesthetize the stretch receptors in the lungs. Basically, you could have something irritate those receptors, but the signal is never going to make it up to the brain because this is basically cutting off that signal there. And so, very handy for like symptomatic relief of like non-productive cough. Typically, if a patient has like a productive cough and it's like, supposed to have an infection, you want them to get rid of that stuff. So it's not necessarily always a great idea to stop cough if it's producing something, right? But for dry cough, it's not really all that useful there. So this is where this may be handy. Um, Keep in mind, don't let patients chew or break open the capsules because the anesthetizing effect can actually happen on their tongue as well. You can see sometimes that with kids and things like that, they chew into it, or because it kind of looks like candy a little bit, as you might imagine. Um, so just be cautious there. Don't cut, chew, or crush it because you can end up losing the effect of the drug and it's going to numb up your whole mouth. Now, one over-the-counter one you might run into is dextromethorphan. Sometimes you guys know it as Robitussin or Delsum. Some of you might know why I put Bender the Robot here. But here you can see that it works by basically, it's kind of interesting because dextromethorphan is kind of like a cousin to codeine, which is actually an opioid analgesic. And actually, all the opioids have antitussive effects in and of themselves, but we don't really recommend, like, here's some Dilaudid for your cough. It's kind of like, using a bazooka to kill an ant or something like that. It's too much. But dextromethorphan is a cousin of codeine, but doesn't actually activate any of the opioid receptors there, but still maintains the anti-cough effects there, which is nice. So very handy over the counter. It can cause like some confusion, excitement in some patients, agitation. Some people just feel really off when they're taking this drug, so they don't really like it so much. But very handy for cough. Not super sedating, but frequently you'll find this in conjunction with like an antihistamine. So you can find things like NyQuil and stuff like that that will, if you ever see like an over-the-counter product and it says something DM, that usually stands for dextromethorphan because it's telling you, hey, it's a cough product as well. So you want to be cautious with that. Some people will abuse these drugs in order to get high, and so that's called robo-tripping, which is why I put Bender here holding a bottle of Delsum. So this is something you'll find with like over-the-counter drugs is that, adolescents will sometimes buy these in large volume because no one's going to really question it in a lot of cases there because it's legal. They can buy it. It's no problem. They can use it to get high, and that has led to seizures and all kinds of bad problems. So I definitely avoid doing that if I were you, because drugs are bad, as they say. There can be some interactions with things like antidepressant meds and things like that because this can potentiate the activities of serotonin. This is kind of like the interaction with linazolid or Zyvox, like we talked about before. So I'd be cautious with this. We'll talk more about serotonin syndrome in a later date, but just be aware of that interaction. And then we have guaifenesin, which is an expectorant. So this is helpful to sort of break up mucus and help you to cough it up and get rid of it. So and it's kind of funny because you frequently will see guaifenesin in addition to dextromethorphan together. So if you see like Mucinex DM or something, you'll see that commonly, the combination. And you're like, well, why would you give an expectorant and a cough suppressant at the same time? And they can, it sounds counterintuitive, but they can provide some additional benefit. So the guaifenesin is helpful to break up mucus, help you to clear it more easily. And then if you still have some residual irritation and whatnot, the dextromethorphan will kind of help to prevent that coughing sort of response from happening in the first place. So there are some instances where it's okay to mix the two, although, again, if you're having a productive cough, I'd want the patient to get rid of that in case it's harboring any bacteria and stuff. So big thing to let patients know here, I mean, almost no side effects with this, besides mild nausea, vomiting, rarely. Biggest thing is let them know to drink plenty of water, because if they are dehydrated and they try to break up that mucus, it's not going to be all that beneficial unless there's water there to help kind of hydrate it, make it more easy to expel, help to decrease that viscosity. So, yeah, so as I mentioned, tell them to expect an increase in drainage. It's not they're getting sicker. It's just they're getting rid of all that gunk that's sitting down there in the lungs. And of course, if they are having symptoms more than 7 days, at that point, it could be something bacterial, so it could be something they need to get managed other than over-the-counter stuff. So have them come in if it's not getting any better. So that's it in the ENT section. I got through that in plenty of time. Let me see if there's any questions up on the board. Does not look like it. Yeah, so nothing else to do this week. Just make sure you get that quiz done if you can. Don't freak out about the grade. I've already adjusted most people's grades already, but there's a few who have not taken it yet. So take this as your last opportunity to go knock that out, please. Again, it's for that portion of your participation grade. It's more for your benefit than anything else, than boosting your grade or anything like that. But yeah, so if nothing else, you guys, thank you for joining me. I appreciate it, and hope you guys have a great day. Otherwise, I'll see you next week. All right, does not look like any questions. So I will sign off. Thanks you all for joining me, and I will see you next time. Bye.